go on mute. A very good afternoon, everyone, and I welcome you all to TOS Vision 2021. This is Dr. S. Badrinath Hall, and moving on to the third session for the day, which is Sharat Babu Symposium, Cataract Surgery, Present and Future. I would like to invite our chairperson. I welcome Chairperson Dr. K.P. Reddy, Co-Chairperson Dr. Haripriya Aravind, and to moderate the session, I would like to invite Dr. Somashila Murthy. Welcome, chairpersons, and over to you, moderator.
Thank you very much, Diksha, for your kind introduction. We welcome everybody to this very exciting cataract surgical session, which is sort of a gaze into the crystal ball of what is going to happen in the future, and also the most recent trends that you can think of and tips to help you in your surgeries in the modern day. So we have really a fantastic gathering of cataract surgeons here for you. Let's start off with Andrew, and he's going to take the keynote for this session, which is going to be what will cataract surgery look like a decade later. Thank you very much, Dr. White, for entertaining my request in putting this talk together for us. So,
thank you very much. I really appreciate the opportunity. It's quite an honor to kick off this session. This is my favorite kind of talk where we basically get to kick around ideas and do a bit of blue sky thinking. So I'll just try and share my screen now, and that should be coming up now, and we should be ready to start. I'm just checking everyone can see that.
Yes.
Yes,
yep.
we can.
Okay, fantastic. Okay, so the talk is entitled Cataract Surgery, What Will It Look Like a Decade Later? I'm based in Sydney, for those who don't know, in Australia, and I'm head of the Department of Ophthalmology at Westmead Hospital, which is probably one of the largest eye units in Sydney. Just normal disclosures that I do consult for various things, various companies, but I don't get any money from them, not a shareholder or anything like that. I do get a lot of research funding. It's actually really great that I'm able to talk about cataract surgery to an audience from India because, as you all know, it was invented there. As far as we know, the first compilation was about 600 BC, possibly the earliest records are 800 BC, from the Shashruta. I've got that horribly wrong, so please forgive me, in Varanasi in northern India. And that was where couching was described, which for most people will be familiar with that. Essentially a sharp implement pushes the intraocular lens still encapsulated to the back of the eye. Certainly it's not terribly common in the Western world these days, but I do have a couple of patients from overseas who are still around, still aphakic and have had couching done. That's just a artist representation of what happened. I still think in the absence of anesthetic, you'd need to be fairly brave. Moving on, really not that much changed up until the Civil War in America, where general anesthetics more or less came into widespread use and the intraocular lens could be taken out completely. The patients were typically left aphakic until Harold Ridley, who was based at St. Thomas's Hospital in London, came along. He was an interesting chap, like most trailblazers are. He was treating pilots in the Second World War who had aircraft plexiglass in their eyes, and because of the viscous nature of vitreous, that attempts to remove it in pre-vitrectomy age led to a lot of retinal detachments, but the plexiglass was relatively inert. And so he fashioned a lens, and the first implant was in 1950. He copped a lot of flack for that. And really up until the mid-1970s, he was very much an outsider in the medical community until his work was recognized predominantly by the Americans. Things remained much the same with intracapsular cataract extraction and initially a plexiglass type lens that was sutured in. Patients were typically in hospital for 1 to 2 weeks and the outcomes were not typically very good. Until another outsider, a guy by the name of Kelman, who was based in New York, introduced phacoemulsification. this is an early photo you can see on the left side here. And basically, it looks like an electronics lab because it was. He used what was effectively a modified dental pick, which is what phaco is at the end of the day, on a blind eye. He had no idea of water-based cooling for ultrasound, and so that eye had a very dense inflammatory reaction and was enucleated very quickly afterwards. But this is a guy that had 5 wives. He was not somebody to be deterred, and he did manage to perfect the technique. However, the lenses really, in terms of what they look like, were really not that different from something that Ridley came up with. So the advantages of phacoemulsification, largely small wounds and rapid recovery, they just weren't really happening until another American by the name of Thomas Mazzocco implanted the first foldable lens in 1984. And modern cataract surgery with phacoemulsification that's basically when it started. It got widespread acceptance really in the late 1980s, early 1990s. And with some flourishes, the basic idea has not really changed very much. You can see here's a variety of intraocular lenses that are available in the market. I don't know why they're mostly Alcon ones, but that was a slide that I took. But they were mostly monofocal lenses, so set for emmetropia in the distance, but for intermediate and near vision glasses were needed. Multifocals have been on the market now for a number of years. I'd like to say they're a jack of all trades and master of none, because they give you good vision at most levels, but certainly not perfect. And things like glare with diffractive lenses can be a bit of a problem. And so for some people, particularly with high level visual needs, target shooters, astronomers, painters, that kind of thing, they're generally not very happy. And there's a basic rule: don't put a multifocal lens in unless you're prepared to take it out again. In the last 2 or 3 years, there's been a new sort of halfway point, which are called extended depth of focus lenses. So the 2 market leaders, well, in Australia anyway, are the Vivity by Alcon and the Eyehance, which is by Johnson & Johnson. They typically, when they go well, give about an extra half a diopter, 0.75 diopter of near vision. And what I tend to counsel patients with is it'll pretty much get you to the level of reading a mobile phone unaided, but you'll need glasses for more than that. Because they don't have a huge number of diffractive rings, they tend not to have some of the glare issues of multifocal lenses. And unlike some of the multifocal lenses, you can actually put them in with people with early to moderate glaucoma relatively safely. Diabetic retinopathy, provided it's not too bad as well. And in the past, multifocal lenses have been contraindicated in those situations. One of the things that we know about them, worst case scenario, it functions just like a monofocal lens, and they don't get the near vision as expected. But generally, I've been pretty happy with them over the last couple of years, and a lot of my patients have them. Modern phacoemulsification machines were up to roughly generation 4. On the left is the Alcon Centurion, in the middle is a Bosch & Lomb Stellaris, and the one on the right here is a new Johnson & Johnson machine called the Veritas, which I've only seen pictures of, I've never actually used. They've all got good fluidics these days, and they're a lot more forgiving than the machines that I learnt on, which were really 1st and 2nd generation machines. What's come on in the last couple of years is something called FLACS, or femtosecond laser assisted cataract surgery. And this is the Alcon machine, although there are a couple of other ones. And essentially, it docks the eye much like you would with a LASIK type procedure. It's got an anterior segment OCT, as you can see on the right of this picture. And once the eye is docked, there's a variety of fragmentation patterns that you can use, but basically it pre-cuts up the lens. So that, and does the rexus. Wounds tends to be a little bit hit and miss, but a lot of people do like it, mostly because it uses the laser and it sounds cool. But it's also, it does make the first steps of any phacoemulsification cataract surgery a lot more reliable. And as we all know, each step in cataract surgery depends on how good your last one was. So it does simplify things. In my private practice, it's usually not in a public practice setting in Australia at the moment. I would say 40 to 50% of my patients choose to have this. We do know that the long-term outcomes of femtosecond laser-assisted cataract surgery versus routine phaco surgery is pretty much the same. What happens in the first few days post-surgery, it's not really, we're not really clear about. I do find that a lot of my patients, because I'm a glaucoma surgeon as well, have fairly shallow anterior chambers. So it does certainly make my life easy in the patients with phacomorphic, early phacomorphic glaucoma, just because you don't have to worry so much about the anterior chamber depth. Other things that have been coming on with imaging is on-the-table aberrometry. So this is the Aura system, again by Alcon. I think there are others in development. And essentially, you have a prediction, and then with on-the-table aberrometry, once the patient is aphakic, you can see how accurate your refraction is. Now, particularly in post-LASIK patients, that's incredibly useful. It does take a bit of a fiddle to set up sometimes. So I do find it a little bit annoying for my routine patients. It does slow stuff down a bit. But one of my colleagues is a high volume refractive surgeon, and I think he uses it on most of his cases. The apparatus is attached to the bottom of the operating microscope, so it is relatively heavy, but you can still do most techniques pretty easily with it. Also, as part of that, they kind of link together. We've got heads-up display, toric marking. So this is the Verion system by Alcon, but there are other systems available, notably by Zeiss, that do the same thing. It takes a lot of the hassle out of marking your toric lenses. A lot of this is now being rolled into new systems where you actually have 3D visualization away from the microscope. So this is the Ingenuity system, which requires 3D glasses. It's really great for nurses and students and other staff around because they can see what the surgeon sees. You can put an OCT in it. They will probably roll in stuff like the Aura or the Verion or those kinds of things. So you've got an all-in-one imaging, but you're no longer looking down the microscope. Most of the advanced imaging is reserved for vitreoretinal surgery at the moment, as you can see below, but I think it will move forward. The ergonomics of the surgery, as you can see here, the surgeon sits at the table. There is a microscope over the patient, but is looking directly across the room at the screen, which they see in 3D with 3D glasses. It sounds like there's a lot of conversion to do this. It's actually no more difficult than, say, playing a piano, and it took me about 5 minutes to do it. At the moment, for cataract surgery, I find it a bit gimmicky. It's got much more utility in vitreoretinal surgery, but as it comes on and we get more adaptive imaging and things such as on-the-table aberrometry and toric marking with a heads-up display become a lot more common, and they will, an all-in-one system like this is probably the way of the future. Now, that's where we are at the moment, sort of pretty cutting edge. And in the last few minutes, I just want to do some spitballing about what the future looks like. So, I mean, one of the things that patients always ask me is, you know, can you get some eye drops that will cure cataract surgery? And in short, no. You can see at the bottom, you can certainly go on things like eBay and you can buy lots of drops that claim all of these sorts of things. But as we all know, the intraocular, the natural lens is a series of concentric rings. I describe it to a patient as much like an onion. And optical clarity depends very much on the precise alignment of those rings. Now, age, free radicals, UV light, it pushes all of those rings out of alignment. So I can't imagine a world where there's a drop that can actually replace that, despite numerous attempts. And I'm sure a lot of people are making lots of money out of things that don't really work. What will be happening as we come along, particularly there's a trend in the United States at the moment. A lot of day surgeries were shut down because of COVID and COVID infections. And so there's an increasing move to office-based procedures attached to their clinic. And here's an example at the bottom. There's a few consulting firms that are looking at implementing this. Because of technology, they use some UVC lighting, sterilization, and there is some development of small portable sterile fields as like a little fume hood. I unfortunately couldn't get a picture of it, but it's about the size of a large garbage bin that just goes around the patient head as a small sterile field. There's becoming less need for an anesthetist as oral sedation is used, and surgeons are doing their own block in this setting too. People are doing it, and there's going to be more and more of that. One thing there's going to be less and less of is post-operative antibiotics. The role of intracameral antibiotics after the ECRS studies is very well understood, and most regulatory bodies are at least encouraging people to use less antibiotic drops as we go along. The last Cochrane review suggests we should still use them, but I know in my own practice it's diminishing more and more as we go along, with the reliance more on betadine and intracameral antibiotics. And I think that trend's only going to go more. And as we look here, these are just some guidelines across Europe, which pretty much say the same thing. None of them are overly prescriptive, but they're all leading towards the same conclusion that we should be using less and less post-operative antibiotic drops and relying more and more on things at the time of surgery. There's some Australian standards that are coming out actually in a week or so that are going to pretty much say the same thing. We're not totally prescriptive, but this is a way that it's going. Now, in terms of post-operative steroids, yes, we need them, but like everything in ophthalmology, I think people will move more towards a depot type preparation, whether that's an injectable gel or something like that. That's more likely to happen. So the majority of patients will actually just have, there won't be as much need for follow-up, and there not as much need for post-operative medications. There's a real move across the world for efficiency dividends for simultaneous cataract surgery. It's certainly done in a lot of outreach camps. I'm sure it's quite common in India. And there's a move across the world. We're not quite there yet. However, the people are studying it. If you look on the right here, this is an article that actually came out only last month looking at the refractive outcomes of immediate sequential surgery versus delayed. It suggests that slightly delayed surgery in terms of refractive outcome is still a little bit better than immediate sequential surgery, but I can see a world where, particularly when there's more of things like on-the-table amerometry, and it's more common, that for a lot of efficiency dividends, people will move back towards immediate sequential surgery, though not necessarily for all cases. Other cool things that are going along, it may well be that you don't necessarily buy and take an intraocular lens off the shelf and put it in the patient. There are some people using UV adaptable polymers where they're injected in. You can change with different light levels what the refraction is essentially within a day or two with UV light. So it's something like that could, in terms, the remnant capsule could just be filled with one of these gels, and with some changes with light, things could be hardened. It's still very much in the experimental stage, but it's still a real possibility of something like this may happen, rather than all the variety of lenses that we have now. Things that are definitely on the way at the moment are built-in information systems into intraocular lens. The ones that people are really working on, in particular, things like IOP sensors for glaucoma patients, and there's a couple of those in development. But I could see that you could also have chemoreceptors looking at inflammatory markers, for example, with AMD or diabetic retinopathy or something like that, that could actually do the same thing. There's a lot of very clever bioengineers out there looking at those kind of things, building them into intraocular lenses. And I'd imagine the first one to market in a serious way is probably only about 5 years off, not 10. The last thing that I want to just touch on with just a minute or two to go, thank goodness, is robotic surgery. Much like everywhere else in ophthalmology, people are developing robotic surgery. The picture on the right is Professor Rob McLaren at the Radcliffe doing vitreoretinal surgery, which has been done a couple of times. Apparently it's quite a fiddly setup, and I'd imagine that for cataract surgery it will be as well, much as the same it is for urological surgery and things like that, where robotic surgery is becoming incredibly common. It's going to take a little bit of time for that to happen commonly in cataract surgery, mostly because the system is too slow, and most high volume cataract surgeons are so fast that for, I think, quite a while, the human is going to be faster than the robot. But eventually, particularly with artificial intelligence prediction and things like that, the robots are going to be better. It's still going to require surgeon control. I haven't spoken to Rob recently about it, but the last I heard, the current setup is incredibly fiddly and not very practical outside of experimental conditions. But like anything, it may change, and this is something people are working on, and working on much more than we know. that's all I had to speak of regarding this today, just kicking some ideas around. I'm, of course, always happy to answer questions. And again, I really thank everyone for tuning in and being part of the audience and giving me the opportunity to speak. Thank you very much.
Thank you very much, Dr. Wright. That was a really enthralling kind of a presentation. I don't think I missed a single word out of it. Atreya, are you sharing the screen or shall I share mine? In the interest of time, I'll just share mine. We wish to welcome Dr. Andrew White. As you know, he introduced himself, which we should have been doing. He's a clinician, scientist, and ophthalmologist at Westmead Hospital, as he said. And his subspecialty is actually in glaucoma, but then he's a top-notch cataract surgeon, as you could figure out. And he has various awards to his credit. He also is a research, he also did his research at Max Planck Institute for Biophysical Chemistry in Germany. And he is both in the Westmead Hospital as well as his private practice. And he has multiple research affiliations, both with the University of Sydney and at the Save Site Institute and the Westmead Institute for Medical Research, where his laboratory, interestingly, is for developing new treatment for glaucoma. But it was really great to hear you take us through the evolution of cataract surgery right from the days of Sushruta, and you got the pronunciation pretty accurate, all the way up to the robotic cataract surgery. That's only part of your talk where I had a little bit of heart turn, because maybe we'll be out of business then after some time, 10 years or 20 years down the line. No, just kidding. So I would like to introduce our two chairs for this session. Everybody, at least in this part of the town or in this part of the country, knows Professor Dr. K.P. Reddy. He also is a pioneer of modern cataract surgery, having evolved through the era of one of the first movers to use phacoemulsification, and also one of the first movers to use the flax or femto-assisted. He was part of the research for all the original machines 10, 11 years ago in India, and some of the machines developed with his research into them. So Dr. Reddy, you heard an amazing talk from Professor White on the evolution of cataract surgery, and just want to listen to your thoughts about it.
Professor White, I mean, thank you very much, sir. It's a wonderful presentation. A lot of insight into what's going to go into the future. But I do remember that when I was last in San Diego, when I was addressing doctors, I did say in all the first world countries in the future, I think the residents will not know how to do a manual capsulotomy. That will be where it will end, because I think machines will take over. But Somshila, you made such an excellent moderation this morning with the live surgery, where I said that in the future, the whole concept of surgery is going to change. And Professor White's talk was so enlightening for me, and I'm sure for all of you. Thank you.
Our co-chair is Dr. Haripriya Arvind. Can you hear me? I think my connection was unstable for a while.
Sorry, Dr. Murthy.
You need to unmute. Haripriya needs
Am I
to unmute.
audible now?
Yes, better.
Yes, yeah.
Yeah, I thoroughly enjoyed the talk, Dr. White. Thank you for your insights. It is exciting. I think the last decade we have seen a lot happening, and the times ahead we're looking forward to further evolutions on the emulsification platforms, the newer IOLs, and also towards drop-free surgery. So I think that's something we also have to look at. What are the different drugs and different modes of using, either NSAIDs or steroids to avoid postoperative drops in patients. So how do we make cataract surgery even more comfortable for the patient? That's something also which we are yet to see. And on the IOL platform as well. So how do we give them good vision, spectacle-free vision with a good quality of life, good quality of vision? That I think is something we're looking forward to in the future. Thank you for your talk.
I think that's just a really great point. I think, you know, for anti-inflammatories and things, there are things that are more than just steroids. And as we know, steroids can create problems, nominally pressure spikes, you know, unmasked keratitis, a whole bunch of things like that. There are a number of biomaterials and chemical companies around looking at alternatives in wound healing modulation. And I do envisage, as I mentioned in my talk, some sort of gel formulation that is slow release and injected at the time of surgery, with hopefully not quite the problems of injectable steroids.
Looking forward to that.
Any other comments or questions from our other speakers? We have a couple of minutes before we go to the next talk. I think Dr. Haripriya, my connection was weak, but I think what you were trying to say was, what I thought you were trying to say was about making the cataract surgery comfortable to the patient. That's a very important aspect. If there was some way in which we could get rid of the patient having to use any drops whatsoever, not just the antibiotics, but any drops whatsoever. So that would be just great.
So we actually are now in the process of trying to give the patients tricot at the end of surgery.
Right.
Giving about 4 milligrams, 6 millimeters from the limbus. In about 1,200 patient days, we have tried it, and we seem to be very happy with the outcomes. Of course, we do have some issues with IOP and eyes. We haven't chosen young patients myopes, but other patients, I think the IOP spikes is probably about 2%. And most of the time it resolves with just medications. We've excised the depot in about 2 patients, but otherwise they have all done fine. So I think there's a lot of other options available today.
Ma'am, you're giving this tricot subconjunctivally or intracamerally?
They're giving it subconjunctivally.
Okay.
Millimeter from the limbus.
Yeah, there was also intracameral
Sheila,
injection. Yes, sir, certainly. Please go ahead.
So Sheila, can I ask Dr. White regarding what his opinion about the future of accommodative IOLs? We had crystallines, you know, calling it as an accommodative, but it has failed.
I think that's a very good question. I just, and I'm also extrapolating from what I know about valve glaucoma implants. I tend to find that anything with moving parts in the eye is going to fail inevitably. It's really just a question of when, and that was a problem with the crystallines as well, that eventually it just got stuck. You know, something other than diffractive, I'm just not that smart to design. But I would like to see more of that because that's what the patients want.
So thank you, Dr. White. We're going to move on to the next talk because the organizers are reminding me that time is money. And thank you for sharing the screen for Dr. Deepak Megur, who's the next speaker. He's par excellence cataract surgeon. Hope you've seen his videos on YouTube, and a very elegant surgeon. He's going to talk about posterior capsular rupture in posterior polar cataracts. We also have, please go ahead, Dr. Megur, you can share your screen. And this is more for Diksha. In case you don't hear me, please go ahead and take up the next speaker because my connection is unstable. Thank you, Dr. Megur. Please go ahead.
First of all, I would like to thank Telangana Ophthalmic Society, Dr. Sheila and Santosh for giving me this opportunity to be on this platform. I'll be speaking on postpolar cataracts, and just let me go at full screen. Okay. As we all know, we are all aware that the incidence of PC tear in postpolar cataract is much more higher than a routine cataract, and we have devised multiple strategies to minimize this. These situations where we want to reduce the incidence of PC tear, but still we tend to have them, and our endeavor is to minimize it to the maximum extent what can be possible. The thought for this This presentation came back many years back when I had a case of a spontaneous rupture in a posterior cataract. And I'd just like to share a video on that. It has got audio. Please let me know if you don't hear the audio. Please let me know about it. It's got an idea. And this was the video which actually...
The common perception is that more is always good. Is it always true? Let's find out. One fine day, I was doing this posterior
Is the audio visible, audible for the video?
Yes, you're audible.
cataract when I witnessed
Yes,
something
it is
extremely unusual. I'm injecting OVD inside the eye. It's the usual amount, but I witnessed something very rare. I could see this posterior capsule rupture happening during OVD injection into the antechamber even before the antecapsule was punctured. Well, I had not seen anything like this in my career. This was weird, and this really got me thinking. I dug deep into my video library and I got hold of 3 more instances of weird spontaneous posterior capsule ruptures happening in polar cataracts. In all these eyes, there is no contact of any instrument with the posterior capsule, but still a posterior capsule tear happened. Let us look at each of these cases individually and try to make some sense on why these things are happening. The first case, this is a 50-year-old myope with a classical posterior polar cataract. I'm injecting dispersive OVD first, followed by sodium hyaluronate, the classical soft shell technique. The OVD is not in excess, it's the usual quantity. But lo behold, I could clearly visualize this posterior capsule split happening, which was confirmed once the cataract was removed. Well, the case was managed pretty well eventually with good visual outcome. The next case, this was way back in 2011, a 25-year-old myope with a posterior polar cataract. I managed to remove the cataract without causing the posterior capsule tear. Now, before going in for cortex aspiration, I've injected OVD inside the antechamber to prevent the antechamber from shallowing. I have religiously followed the commandment of never allowing the chamber to shallow. Now I enter the chamber with my bimanual handpieces. As soon as the irrigation kicks in, the chamber deepens and suddenly I can clearly see these 2 splits and 2 waves there. The first split is the posterior capsule rupture. The second split, the second wave is probably the anterior rupture. Again a young patient with posterior polar cataract. The cataract is successfully removed, so far no posterior capsule tear. Again at every stage OVD is injected whenever the phaco probe comes out to maintain the chamber religiously. Now I need to remove the cortex. Boom! Again the PC splits wide open. Mind you, there's no instrument touching it. Moving on to the last case, this is the weirdest of all. A young patient, posterior polar cataract. I've taken all the necessary precautions to minimize PC rupture. So far so good. And this time the cortex is also aspirated out and still there's no PC tear so far. I thought its job is done. The bag is filled with OVD and I go on to load my lens, and as soon as I'm done and ready to push in the lens, lo behold, what am I seeing here? A large posterior capsule tear is staring at me. Now what caused the posterior capsule tear in all these eyes? There's no direct contact of posterior capsule with any of the instruments. Well, let's try to solve the puzzle. So what is the common link in all these 4 cases, apart from being posterior polar cataracts? Well, 3 out of the 4 patients were young, less than 30 years, and 2 out of them were myopes. These characters, young patients and myopic eyes, lead us to the common link, which is scleral rigidity. To be precise, all these eyes had low scleral rigidity. So what's the big deal about this? When we go back and analyze, a raised infusion pressure is the reason why the pathological posterior capsule split wide open. However, similar phenomenon of spontaneous posterior capsule rupture is uncommon in eyes with normal scleral rigidity. However, in eyes with low scleral rigidity, the sclera can stretch a little bit, which allows more fluid or OVD to accumulate in the eye, which eventually will raise the pressure inside the chamber, and the weak posterior capsule just gives way. So, what can we do in such a scenario? Well, in all eyes with posterior polar cataract, apart from all the standard prescribed precautions taken during surgery, one additional precaution needs to be taken. That would be just to decrease the infusion pressure at every stage in the surgery, from the time the OVD is injected into the eyes to the time the side ports are hydrated. In short, we need to be working on a principle of low flow, low pressure surgery. It's a simple philosophy. Now we'll put these principles into practice and see whether our hypothesis works. This is a young patient with a polar cataract. The OVD is put. The note that the chamber is underfilled, as is evident from the presence of the air bubble and the appearance of the corneal folds during incision. During nucleus aspiration, the bottle height is kept at 50 centimeters with correspondingly low flow rate and vacuum. The posterior capsule continues to remain intact. Similarly, while cortex aspiration, again please note the bottle height. We start with a low bottle height and it's increased subsequently once any antechamber instability is noted. Finally, the eye is maintained soft during IOL insertion, OVD removal, and even during side port hydration. We tried the same principle of low flow, low pressure surgery in the next 8 consecutive eyes of post-polar cataract in patients younger than 40 years. In all these eyes, the eye was kept soft during every stage of the surgery. The bottle height during nucleus aspiration was never above 50 centimeters, and during cortex and OVD aspiration, never above 70 centimeters. And in all these 8 cases, spontaneous rupture of posterior capsule was avoided. Well, in our series, this new principle of low flow, low pressure surgery, along with the old time-tested standard precautions, significantly reduce the incidence of spontaneous rupture of posterior capsules in young patients with post-polar cataracts. The moral of the story is short. More is not always good. Traditionally, we are all taught to be so obsessive of maintaining a deep chamber during surgery to avoid surge. We increase the bottle height, use pressurized infusion, use OVDs to pressurize the eye, but we can clearly see that this can be counterproductive in a select group of patients. So in these post-polar cataract patients with low scleral rigidity, I would say less is more. Less infusion, less pressure inside the eye at every stage, and that's the way to go. To conclude, low flow, low pressure surgery reduces the incidence of spontaneous posterior capsule rupture in these vulnerable eyes. So the next time, please do watch the bottle height. Thank you so much.
Just moving back to my presentation, when we go back and see there is one paper among many papers which have documented the incidence of posterior capsule rupture, but one paper had specifically told that the incidence is very high in patients who are below 40 years of age. So this is one way by which I could correlate with the incidence of PC tears in these young patients in my series. What I could understand here is that when we have, traditionally we are always wanting to maintain a capsule like this so that it doesn't come up. But in patients who are young and who are having low sclerosity in myopes as well, so whenever the pressure increases, sclera expands to accommodate more fluid, and whenever this is stretched, maybe the zonules stretch, the capsule is stretched, and it just cannot take the pressure and eventually just gives in. So in situation like this, I think it's better to have a capsule, a slightly underfilled chamber with the capsule being more forward. It is much more forgiving than you have a situation where the capsule is bowed down. So working on a very soft eye with a low pressure really yields wonderful results in these vulnerable patients. So that has been my observation. And I've been using this technique for maybe last 2 years now, and the incidence of PC tear has significantly reduced in these younger patients and myopes with post-polar cataracts. This is not such a big issue in slightly older patients like 50s and 60s, where the scleral rigidity is good enough. But for younger patients, I found that working in a soft eye has been the trick. And the message here is you don't have to have a very high-end fancy machine with inbuilt intraocular pressure controls. You can use the gravity-based machine as well. Just decrease the bottle height and work in with the appropriate other parameters to compensate for the decreased bottle height. And again, care has to be taken even while inflating the eye at the end of the surgery, even during side port hydration. If you make it a little bit firm, you can see that the posterior capsule can split even at that stage also. And with that, I'd like to end my presentation, and that would be it. Thank you so much.
Thank you, Deepak. That was a mesmerizing video, and every time I see it, I really appreciate. And it's so dramatic, the rupture of the posterior capsule in your video, and excellent points. So comments from Dr. Reddy, Dr. Haripriya.
I lost my screen, so can you hear me?
Yes, we can hear you, sir.
Okay. Dr. Megur, at my age, I have got a great advice from you. I've been doing postipolars without this particular observation. Thank you very much. It's a great presentation.
Thank you, sir. Thank you so much.
Yeah, I agree. Excellent video and clarity. Thank you for those tips.
Dr. White, you had some comments for this presentation?
Well, look, my only comment was I thought it was a great presentation, and I learned something from it. I thought it was just very well done, and that there's a lot of good pearls to take away from that. So well done.
Great. Thank you once again, Deepak.
Thank you. Thank you.
Excellent. Oh, sorry, Rishi has a question.
Yes, I have one question for Dr. Deepak. Beautiful videos. I think everyone's mesmerized. When you're reducing the bottle height and keeping the eye softer, how are you changing your parameters? Are you changing vacuum limit only, or also the flow rate?
Yeah. Because if we want a chamber which has to be stable, right?
Exactly.
So you have to compensate for that. That depends upon your machine's ability to compensate, deal with that low bottle height. The higher end machines, probably you don't have to go back very low on the flow rate and vacuum, but for the mid-range machines, you may have to slow down. So the price you're paying basically is time. The procedure is going to take some more time than your usual surgery, but that's what you have to do eventually.
Dr. Megur, would you also advise preoperative, IV mannitol or Diamox or anything like that?
I used to use IV mannitol before, sir, but I didn't find it any much significantly advantageous. So currently, I'm not using it.
Okay, thank you.
Yeah, I think the beauty in this presentation lies in the fact that, as you said, sir, that in spite of now we all know how to deal with posterior polar cataract, but this is another nuance and a very important one that we should know while managing these cases. So with that, I'd like to invite the next speaker. The next speaker is none other than Dr. Haripriya Arvind. And it's a natural sequence of events, as in we saw so many posterior capsular ruptures, and she's going to talk about IOL implantation in eyes with posterior capsular tear. Dr. Haripriya Arvind is all of you know, she's a very, very famous cataract surgeon, both for her surgery as well as for her presentations and publications. And she's the cataract clinic in charge at Arvind Eye Hospital in Chennai. Over to you, ma'am.
Thank you so much for this opportunity. Yeah, so is my screen visible?
Yeah, yes.
My topic is on IOL placement in eyes with posterior capsule rupture. So once there is a rupture, there are two options based on the amount of capsule support there is. If there is an intact rhexis, one can still consider placing the lens in the bag if the rupture is small. But if there is a large PC tear, or if there is a toned capsular rhexis, one will have to consider sulcus placement. Again, if there's inadequate anterior and posterior capsule support, one will have to think of an alternate placement like a sterile fixation, iris fixation, or anterior chamber IOL. For capsular fixation, if one considers, the best option would be a single piece foldable IOL. For sulcus placement, it's a three-piece foldable or a Babu-made lens. So prior to placing the lens, one has to clear the vitreous and the lens matter. Improving the visibility is very crucial, either with iris hooks or Couplet's hook, and then assess the amount of support and place the IOL. So in terms of improving the visibility before placing the IOL in the sulcus or bag, one very useful device is using iris hooks. So I use iris hooks almost always when there's a PC rent. One, to find out how much of cortex, where the cortex is it a dent or dialysis, how large is the dent, etc. And for the IOL placement as well. So as you can see, one, it becomes very clear the amount of anticapsule support there is when you have the hooks. Plus there's a pseudo deepening of the posterior chamber. So the IOL can be placed, a lot of space is there for the haptic to go in the sulcus. So try to fold the leading haptic so the convex part of the IOL comes in contact with the ciliary sulcus, and then take the trailing haptic in. So having these hooks in place is useful until the end. Only before you remove the viscoelastic is the hooks removed. One can also capture the optic in the rexus margin. Sometimes your pupil may not be too small. In those cases, another option is also to use the Coughlin's hook. So here, I've not used iris hooks, but using a Coughlin's hook, you can retract the iris and then again create space in the posterior chamber and have better visibility of the rexus margin, and then place the IOL in the sulcus. Otherwise, the IOL may go into the back. So a Sinski may not be useful here because a Sinski, the iris will slip. So a Coughlin's or a white hook will serve the purpose. Again, with the trailing haptic as well, the iris is retracted and the IOL will go into sulcus and ensure the optic is captured in the rexus margin for better centration and refractive outcome. The next situation, if the IOL, in case you want to place it in the sulcus, but sometimes without good visibility, the IOL may be placed in the back or may go into the anti-vitreous space, in which case there may be an IOL decentration. So the only option is, you'll have to go back and place it in the sulcus if it is still in the patella fossa. So one will have to bring it back into the anterior chamber and then dial it into the sulcus. Like I mentioned, this is a situation you want to avoid. So a lot of precaution and care has to be taken to ensure you're placing the lens only in the sulcus if your rent is large or if you have inadequate rexus. So ensure you're using the hooks or the Coughlin's to retract the iris and then place the IOL in the sulcus. Otherwise, there's a high chance of IOL decentration in the postoperative period. The other aspect is, if you have intact rexus, it's easier, but sometimes even if you have adequate support to place both your haptics, you still can place the lens in the sulcus. Now, this is again a patient who came in for resurgery, had a traumatic cataract and open anterior and posterior capsule. There is some retained lens matter, so the cortex is first aspirated. The IOL here again is in the anterior vitreous space. So the IOL was supposed to be placed in sulcus, but placed too deep. So it is important to have good visibility and remove the residual lens matter, because this can cause inflammation, obscuration of visual axis. So remove the lens matter completely, and only then, based on the capsule support, does one have to think of the lens. Otherwise, placing the lens too prematurely will make your cortex aspiration more challenging. Here, the rent and the anti-capsule support here is more linear, but there's enough support anti-capsule rim to support both the haptics, and also the support is present on the vertical meridian. So the IOL can stand vertically. So both the haptics are placed superior and inferior. So even with gravity, this lens will not decenter. So this is a situation where you still can place the lens in sulcus, provided you have adequate support for the two haptics, even if you don't have a complete intact rexus. In some instances, you can also place the IOL in the bag. This again is a posterior polar cataract, and this patient has a posterior capsule opening as well. So the phacoemulsification is done. You can see the open PC there. Every time the irrigation is removed, we use dispersive viscoelastic using viscoat here to seal the rent and then remove the probe. With a lot of care, the cortex is removed, phaco is done. And here the rent is linear, but there is support all around. So I'm choosing to place a single piece lens. So for capsular fixation, a single piece lens is more capsular friendly. You can find that you can flex the haptics and then release it in the bag. You don't have to dial the IOL. And this makes it easier for us to do and doesn't enlarge the PC length. So place the IOL very gently in the bag and also place the haptic away from the direction of the dent. In this case, there is some amount of capsular fibrosis over the PPC area, which is gently aspirated with the IA probe, and the IOL is left in the bag. The next case just shows a sequence of managing a PC rent. So in a patient who has a rent fairly early, so one, obviously we tend to think of the lens immediately, can I place the lens, what lens? But I think it's important to take care of the case in a sequential manner. So you remove the nucleus either through phacoemulsification, slow motion phaco, having the phaco probe placed away from the area of the rent to avoid any vitreous prolapse, avoid any enlargement of the rent. So you want neither of these to happening. So very stable chamber with a low parameter and control so that you don't enlarge the rent and don't have any vitreous prolapse. You try to normally remove the lens matter away from the rent first and then go to the rent area more towards the very end. So the rent, as you can see here, is more supranasal, and this the goal is to not enlarge this rent. So the cortex is removed, like I said, away from the rent area first. And the vitreous which is there in the anterior chamber has to be removed before placing the IOL. So vitrectomy is always by manual, placing the irrigation away from the area of the rent, the cutter closer to the rent, and cut any vitreous which may have prolapsed during the procedure. Before placing the lens, I like to enlarge the wound a little bit because I normally do wound assisted for routine phaco, but with the PCT, I would like to take the IOL inside the bag, closer to the bag, inside the anterior chamber. So I'm placing a single piece in the bag because there is adequate support and there is support inferiorly. That's important because even with gravity, the IOL won't decenter. So ensure both the haptics are placed away from the rent area and the IOL is stable. So if the rent were larger, then my choice would be placing a 3-piece IOL in sulcus. So constrict the pupil at the end of the surgery to ensure there is no vitreous in the anterior chamber. Sometimes when we have a multifocal and toric lens, you may have to change and use a regular acrylic 3-piece lens in sulcus if the rent is large. This is a patient who had opted for a multifocal IOL. Things were going fine. This was more like a freak incident where during capsular wash with the hydrocannula, I realized there was a rent on the supratemporal aspect. So with this, since the rent was small, the IOL is being placed. Again, a multifocal lens is being placed. But if the rent was large, then you will still have to go with a 3-piece lens in the sulcus. So when placing the lens, ensure the haptics are away from the rent area. Ensure that your IOL will still be centered. We do not want any kind of decentration in a multifocal lens and any kind of rotation or tilt in a toric IOL. So that you'll have to ensure. And then if the rent is small enough, one can still place a multifocal IOL in the bag. There is some vitreous prolapse, so bimanual anterior vitrectomy is done before injecting picocarbon. This next case was supposed to have a toric IOL. There is some cortex in the periphery which is removed first. This is actually a fairly large PC rent. This patient, a toric lens was placed. This is the hydrophilic acrylic toric IOL. So a toric can be placed only if you think the haptic, obviously it will be in the area where there is no capsular tear. So you should have adequate support for the haptic. So based on the axis where your IOL has to lie, you can decide whether you want to go in with a toric or a non-toric IOL. So if it's a non-toric, then you'll have to have it as an acrylic. You'll have to have a backup of that IOL. I just wanted to show one last case. What happens if you still want to place the lens in the back and you have a fairly large PC rent? Now, this is a fairly large PC rent. So a stepwise approach to this case would be like, first, of course, you take care of the vitreous, ensure the capsule folds, fall back so you know the exact size of the rent. Second, you don't place the rent directly because 1, the pupil is small, 2, the rexus is small. So you want to enlarge these two so you can be sure that the lens goes comfortably in the bag. So the first, the iris hooks are used. Second, the rhexis is enlarged. This way you'll have enough space to insinuate your IOL into the bag comfortably without causing additional stress on the posterior capsule in the bag. The wound is extended and then the IOL goes into the bag, ensuring the haptics, both the haptics are placed over the area where the capsule is intact. If you have a doubt of adequate capsular support, one will still have to think of a lens in the sulcus. So in this case, there is some residual cortex here. So after the IOL is placed, the cortex is in the periphery is removed, the hooks are removed, and pilocarpine injected and antechamber is formed. So in conclusion, early recognition of the PC tear is very important for us to manage the surgery appropriately and place the right kind of IOL.
Thank you, Dr. Haripriya. Such well-managed cases. The most important thing, first of all, is to calm yourself and to try and remember what it is you want to do. And what you pointed out about stepwise. So first address what is there, at what stage the rent has happened, take out the nuclear fragments or the cortex next, do the vitrectomy, and only then think about the lens. So it should not be that think about the lens first. So, but I was just about to ask you, I thought I might see it is about the IOL scaffold technique. Have you tried that? I'm sure you were expecting this question.
Yeah, no, yeah, I have tried the IOL scaffold, but I think that was more, my goal here was about the IOL options. The scaffold is more for the nucleus management, I thought. So that's why I didn't include. I didn't include the iris and scleral suture lens. But if you're placing just a regular PC IOL, what are the aspects you'll have to consider? I just tried to restrict my talk to that. But scaffold, I think, works well. Yeah, more to ensure the nucleus does not dislocate into the vitreous cavity.
Right. Any other comments from our chair, Dr. Reddy, or any of the panelists?
Just like I saw Dr. Meghood's presentation, again, I have something to take home, from Madam. This is beautiful. I mean, especially the idea of retractors, which I never tried. It's fascinating. Madam, would you also use the Suvan Bhattacharjee ring in these occasions instead of the retractors?
Thank you, sir. I prefer the hooks, sir. I think for some reason I have always been more comfortable.
You get a bigger stretch, I think.
A bigger stretch, exactly.
More exposure, yeah.
Exactly. So you
great, thank you.
And you create, because you lift the iris, you
Yeah.
also have that space for the lens to go in comfortably. So it helps in both ways, sir.
It's wonderful. I'm learning. Thank you very much.
Dr. White, anything you'd like to add here?
No, I like the other panelists, I think that it was just a beautiful talk. I have to say I was getting flashbacks from some of my own experiences when this happens, which it happens to all of us, but it was very nicely done. So thank you very much.
Deepak, you've unmuted yourself. Do you have a comment?
And just what Sir was telling, Dr. Reddy Sir was telling that using BX ring in such situations, I think iris hooks have a distinct advantage that the visibility is very good compared to a BX ring, because BX ring you cannot stretch beyond 5.5. Iris hooks, you have a liberty of stretching to whatever quadrant you want to see visualized well. As he himself rightly told, so that's a big advantage. And the madam's presentation was excellent, and she really taught us how to put the lens in the bag in spite of a reasonably big tear.
Right. Yeah, I thought that was amazing. So thank you once again, Dr. Haripriya. We'll move on to the next talk, and hopefully we'll have a little time at the end for discussion. So the next talk is by my friend, Dr. Parikshit Gogte, and he's going to take us through manual small incision cataract surgery. In fact, it's going to be customized. As you all know, that Parikshit is at Gogte Eye Clinic. He's a master cataract surgeon, especially small incision, and he's also my co-member at the Scientific Committee of All India Ophthalmology Society. Over to you, Parikshit.
Dr. Somashila, and thank you for this kind invite to speak in this, panel which has a galaxy of fantastic cataract surgeons. There is Dr. Andrew White and Dr. Haripriya, whom we all enormously admire, and of course my friend Rishi Swaroop and Dr. Deepak Meghood. I'll just start my share screen. is on manual small incision cataract surgery. Can you see my screen and the presentation?
Presentation not yet. We can see the screen. Yeah, it's just opening up.
Can you see the PPT now? Okay.
Yes, you're at the last
Just
slide.
give me a minute.
Sure.
Yeah. So when we think of manual small incision cataract surgery, well, there is always a comparison with phacoemulsification that comes to the mind. So before I start, I would just, well, phaco is today the king of the cataract surgery, and that is what all the fantastic surgeons are showing here. But manual small incision surgery is also a royal surgery in its own right. So about 5 years ago, we had done a meta-analysis trying to compare both these techniques, and in which we had involved 11 studies, and I'm proud to say most of them were from the Indian subcontinent. And there is one Dr. Haripriya's study, which has almost 40,000 cases from Arvind. And there is also Rohit Khanna's study from LV Prasad. And these are the parameters. And we know in the meta-analysis, if this line is as close to the dotted line, both the techniques are the same. So for 618 cutoff, there is not much difference for BCVA. But of course, for unaided vision, phaco is slightly better than small incision. When we look at 6.9, which is the international driving license standard, BCVA, again, no difference. But for unaided 6.9, phaco is definitely better. As you can see, the diamond is on one side. And for astigmatism, there is a difference because phaco is done with is done 2.4, 2.8 millimeters, while SICS is more than 6 mm. But in a single study where we had looked at near vision in phaco, because the distant vision was fantastic, only 16% of phaco patients, when they were put an IOL correcting for emetropia for distance, they had vision better for near, better than N18. Comparatively, almost 81% of SICS patients had unaided vision better than N18 for near, because this astigmatism by a Stroom's conoid increased the depth of focus. So, well, phaco is good because it gives less astigmatism, but this more astigmatism of SICS we can put to so much more use. So as there was this famous Surf Excel ad, kuch daag achhe hote hain, you know, some kinds of blots are good. Well, astigmatism, which is perhaps a blot on manual small incision cataract surgery, can help us give better unaided near vision, even sometimes distant vision. Now I'll be sharing some slides of Dr. Jagannath Boramani, my friend and senior in the International Society of Manual Small Incision Surgeons, who does a lot of high premium lenses, SICS. So obviously these incisions can be tried only once we are well versed with the proper nucleus delivery technique, which in SICS, of course, needs time to master. If we do it well, the final astigmatism in SICS can be less than 0.5. And we can get 6.9 and 6 vision, even in small incision surgery, by doing what is called as a customized incision surgery. We know scleral incisions are very kind in nature, they are secure, they heal well, they are forgiving incisions, there's no incision burn. And we know SICS is an economical surgery, and that's all the more important in a country like ours, where everybody may not be able to pay for the high-end multifocal lenses or toric lenses, which are needed for giving the best unaided distance and near vision. So what the advantage of phaco over SICS is less astigmatism. But if you will see, even with SICS, if we make the incision posteriorly and more frown, the astigmatism definitely reduces. So even with superior straight incisions, the more and more you go behind, the astigmatism is lesser. Even in curved incision, the astigmatism can go to as less as 0.3 diopters, which is comparable to phaco. Again, for temporal straight incisions, it is more, but for temporal curved incisions, it can again be almost as less as 0.2 diopters. So the surgically induced astigmatism can be got to less than half a diopter by doing SICS if we make a frown incision and we go away from the limbus. And of course, if we center the incision on the steeper meridian, then even if somebody has an irregular astigmatism, even that can be taken care of. And because we have a nose in between, well, we have almost 180 degrees in both the eyes, where in SICS we can take the incision, which would not be the case in phacoemulsification. And of course, we have the SIA calculator of Dr. Hill. And if we look at the pre and the post corneal topography, again, there is hardly any difference in diopters, 0.28 to 0.18 diopter. Similarly, for if we are doing a superior temporal incision, again, hardly any difference. If we are doing a superior straight incision, well, again, from 1 diopters pre-op astigmatism, we can make it almost a 0 diopters post-op astigmatism. Similarly, by having this where there is astigmatism, which is again different, if we choose a temporal incision, again, we can completely nullify this astigmatism. Even with a high astigmatism, which is there as high as 3.5 diopters. Normally for phaco, we would always use a toric IOL. But here, because in small incision surgery, the incision size is larger, we can make a bigger incision and we can completely neutralize this astigmatism by having more surgically induced astigmatism. So we are using this more astigmatism actually for our own benefit or for our patient's benefit. Like we have a straight 7.5 mm incision on the steep meridian. It can neutralize more than 2 diopters of astigmatism. So this high astigmatism patient who had an average 3.3 diopters astigmatism, again, post-op, this astigmatism can completely go and become less than half a diopter. So this can be used for multifocal lenses because nowadays patients want not just distant vision, excellent unaided, they also want near vision. So in private practices where we work today, the pressure to put multifocals is increasing because patients demand it, and if their corneas are fine, if their retinas are fine, and they're willing to pay for it, well, we'd be more than happy to put it in their eyes. But then comes the issue of astigmatism. And then we have to think of putting in multifocal and toric lenses, which of course literally hikes up the budget. And well, we are not exactly sure how happy they would be with both the multifocality and the toricness. So this, again, if these multifocal implants are combined with small incision surgery, when the pre-operative astigmatism is much, much more, well, it can be done, and which has a huge, I think, potential or market in a place like ours, where budget is also, it's a significant consideration. So we can put multifocal IOLs without toric by taking care of this 2 diopters of astigmatism, and we are just left with 0.15 diopters. Again, we can have a superior nasal incision for certain incisions. And finally, we have a patient who is 6'6" and N5 or N6 for near. So this is very, very much doable by doing a manual small incision cataract surgery, which all of us are familiar with. And we also don't have to take extra stress because when we are doing a phaco, we have to be very, very careful as far as torics are concerned for their angulation, to see to it that we check the angulation on the 2nd post-op day, again on the 4th or 5th post-op day, to see to it that the lens has fitted well, that the CCC has to be small, that cortical cleanup has to be excellent. There are so many other factors that come into being, which are not there. So instead of calling it surgically induced astigmatism, we can call it a surgically corrected astigmatism. So surgery can actually help correct the astigmatism because of the larger incision. So we use the larger incision to our own benefit. And instead of calling it a small incision cataract surgery, well, we call it a customized incision cataract surgery because we can actually now customize the incision on the steeper meridian, starting from superior nasal, superior temporal to temporal, depending upon where the steeper axis is. So both for the right eye and the left eye, and we can give the best possible vision to our patients. Because today, cataract is a refractive surgery. When we say cataract, immediately phaco comes to the mind. Our patients want excellent vision, not just for distance, they also want it for near. And manual small incision surgery can help achieve it. So we can have reference markings and axis markings. Again, this has to be very, very accurate because on top of that, because that is what is going to help decide the final astigmatism. So with customized tunnel engineering, it is now possible to at least completely do away with astigmatism or at least minimize it. And in this is also a slide I add. I'm a great votary of manual small incision cataract surgery, but we have to understand that even in SICS, there is a trade-off between lesser astigmatism, that is smaller incision size, and corneal clarity, that is endothelial cell loss. If we try to get the nucleus out of smaller and smaller incisions, well, the astigmatism may be lesser, but we may end up with a cornea like this. And everybody is not lucky like Somashila to work with a cornea department. And if they have a cornea like this, they can completely do away in a jiffy. I mean, we have to refer our patients to other surgeons or other cities many a times. So it is not less astigmatism that is more important. We have to think, plan for the astigmatism, customize the surgery, think of each patient, and then perhaps give them the best results. So once more, thank you, Telangana Ophthalmology Society, for giving me this opportunity. Dr. Santosh, Dr. Mathur, and Dr. Somashila. Thanks.
Thank you, Parikshit. I think you have taken us through a different sort of a very, very necessary, probably less glorious described technique, that is small incision, and elevated it to customized incision cataract surgery. I like that, because when you say small incision cataract surgery, most surgeons think that this is reserved for those hard black cataracts where you don't want to do phaco. So the phaco rejects. It's not like that. I think SICS or customized incision cataract surgery definitely has its place. Just a question for you, that in your practice, do you put in torics and multifocals for your patients with customizing the incision?
Not that many, because
okay.
I mean, I learned phaco first in 1997, 98. I started doing SICS in a big way after 2000, 2001. A lot of these slides are Dr. Boramani's slides because he really has large series with them. In my practice, yes, I would do it if the patient is not affordable I mean, a patient needs a toric multifocal, but is not, they just can't afford it. I would do it by small incision cataract surgery. It's not that there's nothing bad with SICS. It's just that I've been doing torics for so many years, is I find it easier to do with them. But as I see Dr. Boramani's results and as I help him write it up, I find it, I mean, in torics, we spend a lot of time, extra time intraoperatively, and then slightly post-operatively. They come the next day, we dilate them. You know, you want to see the axis marking. Just once in a while, it may so happen that they need to be rotated. You take the patient's consent again, you take them and do it. I mean, yeah, the patients have gone through it, so they understand that it is something that is needed. But then, yeah, many a times I think that this extra time, if we spend it pre-operatively planning our surgery and doing it, and if somebody does a lot of small incision surgeries, and if you are quite sure of the astigmatism that you would be giving it, and nowadays there are so many algorithms, like there are algorithms for multifocals and phacos, there are algorithms for astigmatism and SICS, that it is possible. So yes, I don't claim to do a lot of them, but I am doing it. But I have found that in so many of the SICS patients we do, and I do a lot of them for camps and this, they are very happy for their near vision, which is not the case for our phaco patients. We are happy they are 6'5" or 6'6" unaided next day. They say, doctor, I could read the newspaper or see the mobile 2 days before. Now I cannot do that. So we have to think of that also.
Very important point, Parikshit, the observation that the unaided near vision was actually better for these patients. So any other comments from our chairs or any of the other panelists?
I just would like to say, Dr. Parikshit,
Yes, sir.
You know, I never did a small incision cataract surgery. I don't even know how to do it. But your presentation is making me think at my age to go back and start doing SICS.
Wow,
It's
sir.
really
No,
great.
you are an
It's really
innovator
great.
for excellence. So if, I mean, no. I
Yeah,
mean,
it's
would be a
really
privilege.
great. I think it's really, thank you very much for all the information. It's wonderful.
Thank you, sir.
Thank you, Parikshit, once again. We will move on to the next speaker, and the next speaker is Dr. Sheetal Brar. She is a consultant for phacoemulsification and refractive and cornea at Netradama Super Specialty Eye Hospital, Bangalore. She is a very astute cataract surgeon and has multiple publications both in cataract and refractive. So she's going to show us her tricks and techniques to handle the hard cataract. Over to you, Sheetal.
Thank you so much, Dr. Somshila. I'll be sharing my slides. Are my slides visible?
Yes, they are.
Yes, they are, Doctor.
Thank you. So at the outset, I would like to thank Telangana Ophthalmic Society, Santosh sir and Somshila for inviting me to this wonderful session. I'm really enjoying it, and I'm particularly thrilled because not just because we have a galaxy of stars of cataract surgery here, but also I have two of my most favorite ladies in ophthalmology participating in this session, Dr. Haripriya Arvind, who is my very respected mentor from Arvind Eye Hospital. I have learned a lot by observing her surgery as a fellow 9 years ago. And it's a big honor for me presenting in front of ma'am, and also Somshila, my wonderful friend, supporter and well-wisher, who herself, as we all know, is a wonderful person, great teacher and mentor and researcher as well. So thank you again for this great opportunity. I will be talking about devices to tackle the hard cataract, and my favorite device in this category is the MyLoop device, which is available with Carl Zeiss Meditech currently. So as cataract surgeons, we all are well aware of the various complications of hard cataract, such as wound burns, zonular dialysis, PCR, nucleus drops. All these can happen on hard cataract. Sometimes the cornea can also decompensate. The corneal edema can be very severe, which may take a very long time to resolve. So these are the complications and how we can avoid the management. Of course, I'm not talking here about the management of hard cataract itself, but definitely for any surgeon, it's very important to master a surgical approach, which involves use of proper fluidics and power modulations, as well as what is more important is the way we dismantle the nucleus. So of course, the chopping techniques are much better compared to the trenching techniques. And when we use the routine instruments such as the phaco probe and chopper, we have to do multiple chops, separate these pieces more widely. So all this actually increases the surgical time. We use higher amounts of energy, as well as there is a chance of having a capsular injury and potentially sight-threatening complications. So previously also in the past, some instruments have been devised to improve safety in hard brown cataracts. One of this instrument was a snare, which was introduced by Keener in 1983. This was a stainless steel snare, which was in the form of a wire loop. And this was supposed to be used, designed to be used through sclerocorneal tunnel in SICS. Yes. And after the nucleus was prolapsed in the AC, then this device was to be used to bisect the nucleus. Yes. The disadvantage of this was that there's no long-term publication on this. However, we can assume that when you are using the instrument after the nucleus has been prolapsed in the anterior chamber, it can touch the endothelium and can cause potential endothelial cell loss. There was this instrument pre-chopper, which was also introduced by Dr. Akahoshi from Japan. And this was promoted as a zero energy energy manual and mechanical device to bisect the nucleus. In phacoemulsification, this was possible to be used with phaco through a clear corneal incision. However, this was a little difficult to master. The learning curve was steeper, and in cases of very hard brown cataracts, it was found not to be very efficient. The recent advancement in this field is the use of femtolaser technology, as we all know. And to some extent, femtolasers also help in hard brown cataracts. They reduce the phaco energy being used to emulsify these cataracts. However, limitations still remain. The technology is expensive, and in very, very hard brown, those black cataracts, the laser cannot penetrate into the deeper layers, and the posterior leathery layer is not affected. So in these cases also, laser is not 100% effective. So this was until recently when Professor Sean Ankla from New York Eye and Ear Infirmary, who devised an instrument called MyLoop. So MyLoop, the full form is micro-interventional microfilament loop-like device. He designed this device for hard brown cataracts. This has a loop and an actuator. So this idea originated actually in a very interesting way over wine and cheese, when he observed that it was much easier to cut the cheese when a wire was used instead of when a knife was used. So this is how this brilliant idea originated, and these are the specification of this instrument. It is a micro-thin filament loop-like structure of 300 microns thickness. It's very thin, and it is made up of an alloy of nickel and titanium. This alloy is called nitinol, and the property is basically it is a super elastic material, and it has an excellent shape memory. So the loop can actually fold from a fully expanded radius. So when it is fully expanded, it is 10.5 millimeters, and when it is contracted, it comes down to a size of 1.5 millimeters radius. So from a 10.5 to 1.5, when it is contracted, it still maintains its integrity without losing its shape. So that is the speciality of this particular material. So this is how this instrument is actually used. This is the dry run of the instrument. So the blue part is the
I think it's Sheetal's connection which is poor.
Dr. Sheetal, can you hear us?
Sheetal, I think your connection is poor. Okay, we lost Sheetal's connection. Can you
Dr.
call?
Murthy, can you hear me?
Yeah, I can hear you. Yeah.
Okay, perfect. I think
yeah, we lost your
Sheetal has
connection.
lost the connectivity here.
So are we contacting her?
Yes, doctor, we can go ahead with the next talk. So we can.
Dr. Murthy, maybe we wait for 10 seconds.
Yeah, sure. Yeah.
Yeah.
I'm just calling her actually. So that's
Sure.
what I'm trying to figure out.
Sure.
So what happens is when you're the speaker and you get disconnected, you just don't realize and you keep talking in space.
Yeah.
So the same thing happened. She kept talking. So that's one big disadvantage of online meetings. Yeah.
I can see. Hi, Dr. Sheetal.
I'm connected again. I'll be sharing
Yes,
the slides
Sheetal.
again.
Yeah. Yeah. You were talking about MyLoop and you were describing it to us.
Yes. I'm so
we're
sorry
halfway.
about this. Yes.
Also took me a while to figure out whether my connection was bad.
Showing my connection is unstable. I hope it doesn't.
So maybe you can switch off your video and but share your screen for your PowerPoint and just use your audio.
Yes. stop my video. Okay. I think I already discussed this.
That's right. You were talking about the MyLoop
The MyLoop
description of.
specification.
That's right.
Yes, yes, yes. Okay. So I was just showing you the dry run of
Yeah,
this
you were here.
instrument.
Yeah.
Yes. So there is this blue part is the actuator. So when you advance the actuator, the loop opens. See, you can see this opens in the form of how the bag is, the capsular bag is. And when you contract it, it becomes small. So let us see the use of this instrument in real case scenario. So this is a case of a 70-year-old male with grade 4+ cataract, so almost like a black cataract, for whom a toric lens is planned. So what's more important here is you have to have a rexis of 5 to 5 millimeters and a good hydrodissection for the loop to introduce smoothly. So when the loop is introduced, you have to first open it in the coronal plane and then open it fully and then start rotating it to 90 degrees and make it vertical. So once the instrument is vertical, you will actually see a sheen of the instrument going behind the hard nucleus. And then you have to use the second instrument from the side port, support the nucleus, and then you have to pull the actuator to crush the nucleus into 2 parts. So once 2 parts are made, then you can go ahead and take another pass in the similar way and make 4 pieces. So you can take 1 to up to 3 passes so that you can break the nucleus into 6 pieces, but usually 4 pieces is good enough. So once the nucleus is divided into 4 pieces, it becomes very easy to emulsify them. And what is great about this instrument is that it bisects the nucleus completely. It does not leave any area uncut. So it is just like once it is divided, just picking the nuclei, the pieces and emulsifying them becomes very easy. Of course, you have to use OVD liberally. And once the job is done, you can go ahead and place the lens. So for this case, this black cataract, this was the post-operative picture at 3 days post-operative. First day there was a slight corneal edema, but which cleared by 3rd day. And you can see that the CD in this particular case was 23.12. So despite using the MyLoop, the CD on the higher side, but we can imagine if we had not used MyLoop, we would have definitely had a CD of 40+ or even more. So this is quite useful here. And showing another case just to show the importance of the size of the rexis. So if your rexis is very large, like in this case, this is what happens. So the nuclear pieces can actually prolapse out of the bag, and then there is a risk that these pieces can touch the endothelium. So make sure that the rexis is 5 to 5.5 millimeters only. If it is too small, then what can happen is that when you are withdrawing the MyLoop out of the eye, it can snag the capsulotomy margin and can cause a tear. So you have to be very careful there. So a rexis size of 5 to 5.5 is desirable if you want to use MyLoop. This is another case of 68-year-old female with a dense brown cataract. The pupil was mid-dilating and the AC was shallow. She had post PI also. So I'm using a Malugin ring here first. This is just to show that you can use MyLoop even with the use of MyLoop with the Malugin ring and other pupil expansion devices, and it does not interfere in the MyLoop, and it does not cause any additional complications. So the nucleus was first bisected into 2 pieces, and then a second pass was taken to make 4 pieces. So it's very important to stabilize the nucleus, because if you don't stabilize the nucleus, these 4 pieces, they can prolapse out of the bag and touch the endothelium. So that's something you have to be careful about. So once the nucleus is emulsified, then the ring can be removed, IOL can be placed, and ring can be removed in the usual way. I'll just skip this. We have also done MyLoop-assisted surgeries in dense cataracts, which are also associated with subluxation, minor subluxation. So this case, the video is not working, but you can see from the picture, there was almost 3 clock hours of subluxation. And here also very safely we were able to do the surgery. And at the end of the surgery, we placed a CTR. You can also use MyLoop in cases of small incision cataract surgery. So this is a case of a 99-year-old female where there was a hard brown cataract. Pupil was small, so I used a Malugan ring. And my rexes ended up being a little small for small incision cataract surgery. So I was not very sure whether I would be able to prolapse the nucleus. So I used MyLoop here and bisected the nucleus into 2 halves. So when you're introducing the MyLoop, it's very important that you first open it fully. You open it fully and then start rotating. Stabilize the nucleus. And then bisect. So the hard brown nucleus is bisected into 2 halves, and then each of the pieces is extracted out of the eye safely. Without any complications. So MyLoop allows for single-handed atraumatic zero-energy centrimeter nucleus disassembly, and it ensures full thickness microsegmentation. And irrespective of the nuclear density or grade, it cuts the nucleus completely. So the advantages, as I earlier also said, that it is possible to be used in a variety of complex cases like pseudoexfoliation, small pupils with the pupil expansion devices, mild cases of subluxation, and in SICS, in routine SICS also you can use it to reduce the incision size. Also, it causes minimal zonular stress because the forces are centripetal and not centrifugal. And the PCs are much cleaner because when you are looping the lens, it also clears the sticky cortex, and it also protects the endothelium because the deployment is happening within the bag. However, we have to be cautious. I mean, posterior polar cataracts are a contraindication for MyLoop, and also if you have any anterior capsular tears. So to conclude, in our experience, we find MyLoop as a very safe and effective device to tackle hard brown cataracts. Our intraoperative have reduced significantly, and our immediate post-operative corneas are much clearer. So I would just want to say that MyLoop is a device that makes an average surgeon brave and a brave surgeon much more efficient. Thank you so much for your patient hearing. And if there are any questions, I would love to take them now. Thank you.
Thank you, Sheetal. Just a marvelous presentation. I think it's a brave surgeon only. I don't think average surgeon can use it. One question that I had before we go on to the others is that how is it? So have you had any complications maybe in your learning curve when you used it?
I can say that I may have used MyLoop in over 100 cases now, and I've not had a single complication with this. Because what we have to understand, a lot of people ask me whether there's an increased risk of PCR or zonular dialysis. Actually not, because if we understand the mechanism, how it works, if you see the shape, it is in the shape of the capsular bag. Okay, so when you introduce in the anterior chamber, you have to first open it fully, and before you start, and then you have to start looping it around. So it actually accommodates the complete nucleus, and then you bisect it. So there is no chance that the PC can come, and the forces are centripetal, which means from outside to inside. So it doesn't cause zonular stress and problems with zonules. We have also used in subluxated cataracts also without issues.
Great. Just because we are running short on time, so thank you very much, Sheetal. I know you have to get back to clinic. Thank you so much for participating in this session and showing us this wonderful technique. And hopefully some of us can start using it.
Thank you so much for the opportunity.
Bye.
Bye.
So we'll go to the next, the penultimate talk for this session. And that's by none other than our friend, Dr. Rishi Swarup. He's the medical director, senior consultant of cornea at Swarup Eye Center in Hyderabad. And he's obviously one of the other surgeons here who's blessed that if they have corneal edema, which doesn't resolve, then we can just go ahead and do keratoplasty. Not that we're suggesting it. But Rishi, incidentally, you might remember that you're one of the two surgeons who actually, yes, is going through Parikshit was talking about, just reminded of that. So thanks for joining, and please go ahead.
I cannot start sharing till somebody else stops sharing.
Yes, sir.
Yeah.
I'm sorry.
Yeah, okay. Visible on my presentation screen?
Yes, we can see your
Yes, to both.
Okay, and all right, I'll get started. Thank you, Dr. Somshila, for inviting me to be part of this session, which has such fabulous speakers. I feel very small here, but thank you nonetheless. So this is one of my favorite topics, cataract surgery in the setting of keratoplasty. I'll try and stay to time. So when you're talking about cataract surgery in the setting of keratoplasty, it can either be cataract surgery being done after a keratoplasty has been successfully performed, or when you're combining it with a keratoplasty, which may be anterior lamellar, posterior lamellar, or penetrating. So we'll just cover these two scenarios. When you're doing it after a keratoplasty has been performed, which often is a penetrating keratoplasty, one must remember that you should do the technique which is more friendly to the cornea. So if in your hands an ECC is going to work better, please do that. If you think SICS works better, please do that, depending on the cataract, of course, and the rest of the situation. I often like to do a manual small incision cataract surgery in many of these post-keratoplasty eyes. So this particular eye was a post-therapeutic graft, maybe a month or two after surgery, but you can see the cataract has become very intumescent and the AC was very shallow and the IOP was going up. So I had to quickly go ahead and do a cataract surgery in this situation. And you can see that the advantage of a manual small incision is that your incision is peripheral, it's outside the graft, and your entry can be quite peripheral as well. So you don't need, you can probably enter outside the graft versus junction and make a large incision through which a big nucleus like this can be safely removed. And if you are gentle with your surgery, you can basically take out the entire cataract without the nucleus coming in contact with the endothelium, as you will see very shortly. I like to use the Blumenthal technique, which I think is very good for any size of cataract. When you're doing a phacoemulsification, some principles have to be kept in mind. Always, your incision is very important. So try to enter in an area where you have enough peripheral cornea outside the graft. So if it's an eccentric graft, choose a location where you have more peripheral cornea. Use as small an incision as possible. And of course, use good instruments. You could use a clear corneal incision. Otherwise, a scleral incision is probably a better idea. Use whatever viscoelastic will help you minimize damage to the endothelium. So either a soft shell or a viscoadaptive OVD. You want to use slow motion phacoemulsification with as minimal endothelial damage as possible. Intermittent injection of viscoelastics, and try to do your emulsification as away from the endothelium as possible. The intraocular lens also has to be chosen carefully. Avoid multifocals or trifocals in these eyes because there will be some sort of irregular astigmatism, and you will not, you might end up with an unhappy patient. Try to go with monofocal. Toric IOLs can be used, but you must make sure that the astigmatism is largely regular. IOL calculations sometimes can be challenging, and that's a completely different topic which I won't go into. So just when you're using toric IOLs, just remember that if the patient was already an RGP lens user, for example, please don't go and put a toric IOL in this eye because then the patient will not be able to use RGP lenses afterwards. And if you have residual astigmatism or irregular astigmatism, which was being corrected by the RGP, he will not be happy afterwards. Second thing is only use these lenses after all sutures out. In fact, in all keratoplasties, always put the lens in or do the surgery after sutures out and the cornea has stabilized, because otherwise you will have change in refraction postoperatively. So this was just one case in which a 7 diopter cylinder could be corrected very nicely with the toric lens and patient got a fabulous result. That was penetrating keratoplasties. Again, deep lamellar keratoplasty. Essentially, everything remains the same, but you must remember that you have an interface there. So whenever you're entering with your instrument, you can end up detaching that interface. So try to do a spiral tunnel in these cases and enter outside the graft. The rest of the principles are pretty much similar. We have a custom smart toric lenses available in India from Care Group, in which you can you get cylinders as high as 15 or 20 diopters. So very useful in post-keratoplasty situations when sometimes you can end up with a refractive surprise of very high cylinders. And I've used some of these with very good results. Only thing you have to remember is these lens edges can be quite thick. So you need to make sure your rhexis is large enough and you don't end up struggling putting the lens into the bag. So this is just some more examples. We got very good results with toric IOLs after deep lamellar keratoplasty. This is just one patient where I had a problem. I'm using a clear corneal incision. I'm not able to see the timer in these. Okay, I can see it. Yes. So you can see I'm introducing my phaco probe, and I was a bit careless. I made a clear corneal incision and I didn't realize that I actually went into the interface. And you can see as soon as I'm trying to aspirate that loose cortex, nothing's coming. And I still didn't realize it. You can see that shiny reflex at the back. And I use phaco, and there I go. I made a hole in the desmus membrane and Dua's layer, and I'm so unhappy at this moment because this was a beautiful talc which I have ruined. And eventually this patient needed a endothelial graft to again regain the clarity of the cornea. So when you're doing cataract surgery after keratoplasty, please remember a few things. Respect the boundaries of your graft. Enter through an area where there's enough space. If possible, use a scleral tunnel. Respect the endothelium. That's very, very important. So keep using a lot of viscoelastic, low parameters, and use the appropriate lens and the appropriate technique, whichever would be friendly to the graft. Toric IOLs can be used selectively. Cataract surgery, when you're combining with a keratoplasty, so it can be a DALC triple or an endothelial keratoplasty triple or a penetrating keratoplasty triple. So when you're doing a penetrating keratoplasty triple, one would of course like to do closed chamber phacoemulsification first and then do a penetrating keratoplasty. But if you don't have good visibility, then traditionally what we've been doing is we excise the corneal button and then do an open sky cataract surgery. These were essentially the two options that we had. But I don't like to do the second option because open sky cataract surgery has its risks. I'll just talk about those. This is one scenario where we have reasonably good visibility. This patient has a scar and an irregular cornea. So we're doing a femto keratoplasty along with the cataract surgery. The femto cut has been done, and through a limbal incision, I'm doing the phacoemulsification. Now, advantage is because when you're doing a penetrating graft, you don't really care about the endothelium. You can bring the pieces right next to the endothelium, emulsify them there safely. You don't need to do an in the bag phacoemulsification, especially when your visibility is poor. So that's what we're doing here. And you can see it goes very smoothly. And then you open up the graft here. We have a mushroom cut. You can see the ledge there. And then the rest of the surgery is just like any regular penetrating keratoplasty. If your visibility is not poor but fair, you could still go ahead and do a penetrating keratoplasty after doing a closed chamber phaco, but you have to do some special maneuvers. For example, if your epithelium is very hazy, like if it's a bad endothelium, removing the epithelium sometimes can really improve your visibility, which is what we're doing here. You can use trypan blue to stain the capsule so that your rhexis becomes safe. You can put dispersive viscoelastic on the surface of the cornea so that you can see better. All the irregularities are smoothened out. And then one more thing you can really use is an endo illuminator. It really helps to see things inside the anterior chamber and makes your steps of surgery much safer. And of course, you can remove your pieces into the anterior chamber and emulsify them safely there. Again, endo illuminator can be used for all steps, not just for rhexis. I don't know why my slide is not moving. I'll just exit the slideshow. Sorry about that. I'll just share my screen again. Yeah. So I've shown you this video already. Now, if you have poor visibility, what will you do? So an open sky surgery is what we've been doing, but I don't like to do that. So what I have started doing is I do a lamellar keratectomy so that I reach a level where I can start seeing better. And then I do a closed chamber phaco like I just showed, and then convert to PK. And because of this, I've almost given up doing open sky cataract surgery. So this is one of my older videos in which we did an open sky triple. You can see everything's going very well, and I've done some co-wash and all that stuff and put the graft in. So very often you get away with it and have a good outcome, but sometimes you can have problems because it's an open sky. You have positive pressure. You can have risk of extension of your rexus. You can rupture the capsule during IA, and you can lose vitreous. And then once you do that, the outcome of your surgery is really compromised. You may not even be able to put the lens, and of course, there's always the risk of expulsive, which is looming on your head. That's something you just don't want. So this is what I've been doing for these cases. So this was the patient with the macular dystrophy. So you can see we're doing a lamellar keratectomy. This is what I call the new PK triple. And once you reach a stage like this where your visibility is reasonably okay, once you put the dispersive viscoelastic, you can see almost everything quite well now. And then you just go ahead through your limbal or spherical incisions. You can complete your phacoemulsification. You can, of course, use an endoilluminator, etc., to make your visibility better, like I've shown earlier. And after everything is done and the lens is put, you just go ahead and remove that posterior layer of posterior stroma and endothelium and put your new graft in and suture it just like you would in a regular penetrating keratoplasty. So that's penetrating keratoplasty triple. And then DALC triple, you could remove the entire stroma and do the phaco just like I showed you with the previous videos. But if you just go down to all the way till the Duas layer, sometimes the posterior layer bulges and you have visual distortions. Also, it feels a little unsafe. So I've stopped doing that. I try to do lamellar dissection and do the phaco and then remove the rest of the DALC. Endothelial keratoplasty triple, of course, is something we're doing more and more now because the results of endothelial keratoplasty are so good, and it works better if you have a pseudophakic eye. Otherwise, later if you have to do phaco in these eyes, sometimes it can be difficult. So we were doing it DSEC earlier, and now we are doing it with DMEC. Main thing you have to remember is whatever endothelial keratoplasty procedure you're doing, try to use a cohesive viscoelastic rather than a dispersive, because otherwise this dispersive viscoelastic go into the interface. So finish your endothelial keratoplasty procedure and then go to your phaco. Use a cohesive viscoelastic. Descemet stripping is not necessary in a post-graft scenario. You can directly go ahead and put the endothelial graft also. IOL power adjustment has to be done. In a DMEC, it's not necessary, but for DSEC, you have to go for a myopic IOL because you do get a hyperopic shift because of the lenticule of DMEC or DSEC. And finally, the lens material should be hydrophobic acrylic rather than hydrophilic acrylic, because when it comes in contact with air, it can have calcification, which can compromise the outcome. So to conclude, cataract surgery in the setting of keratoplasty requires special attention and modifications to the standard technique to have safe and effective outcomes. Closed chamber phacoemulsification is possible in almost all cases of triple procedures with some special maneuvers. Pay attention to lens power, material, and design, and respect the graft, and it will give you good results. Thank you.
Thank you so much, Rishi, for finishing right on time and giving an amazing talk, which covered practically all aspects of grafts and cataract surgery, either simultaneous or pre-graft or post-graft. So thank you for that. We'll probably have to go on to the last talk without any questions for you, Rishi. Anyway, I think that your presentation was so good that there may not be too many. And the last speaker for this session is Dr. Abhinav Biala. Biala is my young colleague from LV Prasad Institute till recently. And just this month, he's decided he is going to go back to Delhi and start his own, to Gurgaon rather. And so we've gone through the entire gamut of presentations today where we learned what is going to happen in the future, as well as looked at various techniques and difficult scenarios. What Abhinav is going to do for us is talk to us about training, and not just the routine kind of training, but simulator-based training. Abhinav, over to you.
Thank you, Dr. Somshila, for that introduction, and also thank you for giving me this opportunity to speak here. I hope my slide is visible.
Yeah.
Yes.
Yes, all right. So I'll try to go slightly off topic this afternoon from cataract, I would say, and then try to, at the end of my presentation, try to align with the cataract surgery that we've all been talking about for the past 2 hours. So the topic of my talk is simulator-based cataract training. So whenever we hear the word simulator-based training, the first thing that comes to our mind is simulator-based training for flying or in the aviation sector. So in this presentation, I would like to talk to you about a few objectives. First will be the importance of simulator-based training in aviation. Then the need for such kind of training in ophthalmology, the advantages of such training, and at the end, I would like to also show you a demonstration video on the simulator. So simulation is basically an examination of a problem, often not subject to direct experimentation, by the help of a simulating device. So here we are talking about simulation-based training using a cataract surgery simulator, and not practicing cataract surgery directly onto the live patients as has been done conventionally in the past. So as I alluded to, that I'll be talking to you about simulation in aviation. So this is how a simulator used for pilot training looks like. It's a small room which is balanced on these 3 tripods, which you can see here, and the whole room setup moves either front, back, left, or right, depending on how the pilot is maneuvering the aircraft from inside. And as we step inside this room, you have this original cockpit, which has been transferred from an actual aircraft into this room. And you have these 4 screens, which show you the external environment on the different displays based on the different kind of airports that you are at. Thus, behind these 2 seats is the seat of the examiner, where the examiner sits. And you see a lot of controls at the palm of the examiner, which helps the examiner to create different kind of simulations, simulations for an engine failure, simulations for a bad weather, a simulation for the landing gear of the aircraft not coming out. So different kind of complications like we have in cataract surgery. So different kind of situations can be simulated in the aviation sector, and the pilots are trained to tackle these situations with the best of their expertise. So what is the advantage of the simulation-based training in aviation? So you see the safety word being in a very large font as compared to the others. That's because that's the utmost need of the hour. That is the safety of the passengers which are flying in these aircraft. Then the next biggest factor is the cost of the aircraft. So you see there that number, what you see is not my phone number, but that's the cost of the Airbus A320 aircraft, which all of you must have flown in. That's the cost in Indian rupees. Then there is always a controlled environment, and every simulation that is being done can be controlled by the examiner. So there's no risk of anything going out of hand or any physical damage being there. Next thing is the repetition. So suppose if one part of the simulation the pilots are not able to clear, or they fail at that one part, they can always go back, they can always repeat that same part n number of times and at any time they want. Then for comparison purpose, they have the measurement metrics, because it's a computer-based program. So the measurement metrics can help objectify this simulation training. So and it can be compared to their other peers, or even their seniors, even their seniors for that matter. And yes, lastly, since it's a computer program, it doesn't use an actual aircraft, so there's no emission of any kind of harmful gases. So it's environment friendly. So why do we need such kind of training in our ophthalmology field? So most of the times, the closest simulation that we have of the human eye is mostly the goat's eye, or in the recent days, there's the wax eye model. But we all know that both the goat's eyes and the wax eye model is not as close to the real thing that we actually operate upon. Then in order to have a level training field for all trainees, so we all know that all eyes are different. Some eyes may have a deep anterior chamber, some eyes may have a shallow anterior chamber. The scleral rigidity keeps on varying from eyes to eyes. The pupil size keeps on varying. So it's not a level playing field for a trainee who comes into cataract surgery training. Then as compared to conventional live surgical training that we have, the simulation based training is much more faster. It also gives much more time to the trainee to practice one step over and over again. And also, it can also train a large number of trainees in the similar time that we are used to training in the live conventional live surgical training. Then, since it's also a computer-based program, we also have objective metrics which can be used to compare the performance of the different trainees. And at the end, because of this COVID pandemic, the availability of patients for surgery has decreased significantly. So here in the simulator-based training, we don't require any patient. We have a machine on which we can practice. So the advantages here are almost similar to the ones in the simulator-based training in the aviation sector. So most important is the patient safety. So here the trainee is learning to do the surgery and without the risk of any complications happening on the actual patient, and thereby, you know, having the chances of having decreased vision for the patient post-operatively. The conditions are constant. The eye that the simulator presents is absolutely same for all trainees. So it's a level playing field for everyone. Then a single step like say capsular access or say nucleus delivery or say scleral wound construction can be practiced again and again, whereas that cannot be done in the live surgical training. For you to practice nucleus delivery, you have to first go till the part where you do nucleus delivery and then you practice nucleus delivery. That's not the case here. You can directly go on to nucleus delivery and you can practice the same. Since there are objective metrics here, evaluation is much more easier. And in the future, there might be also possibility for remote training where a trainer might not be present in the close vicinity of the trainee in order to help the trainee learn. There has been extensive literature published for simulator-based cataract training in the past. And recently, along with Help Me See, LVPI has also published the effectiveness of the simulation-based training, which was the first randomized controlled trial. So we achieved the simulator-based training with the help of Help Me See. It's a non-profit organization, which was set up by late Mr. Albert L. Ucci. He was the head of Flight Safety International, and he also led Orbis International for close to 30 years. And in the time that he was training the pilots, it occurred to him that why not it can be used for training of the ophthalmologists. So with that said, I would like to directly jump into the demonstration of the simulator. So if you see my screen, you have these 4 modules which have divided small incision cataract surgery into these 4 parts. And then if you go further into these modules, you'll be able to see that, I'm sorry about that. Yeah. So if you go further, under each of these modules, you have a list of these 7-8 subheadings which are there encompassing all the different steps. So here I'm trying to demonstrate a scleral tunnel construction. On the top right, you see there's another secondary camera that's showing you my hand positions as I'm doing the different as I'm doing the different steps. So here I have a crescent in my right hand and a colibri forceps in my left hand. But if you see, actually, those instruments are just a pair of those haptics which are there mounted onto the simulator, which I can use to emulate any kind of instrument which is required in cataract surgery. So I'm done with the tunnel. I'm done with the scleral incision, and I'm going ahead with the tunnel construction. And if you see closely, you can see that blood which has seeped into the tunnel being very nicely shown on your screens right now. So the Help Me See team has put a lot of effort in improving the the graphics and the realism that the simulator presents to the trainees. So another important thing is I would like to talk to you about is the secondary camera. So many a times when we are teaching the trainees, we don't pay attention to how the trainees are holding the instruments in their hand. So this secondary camera helps us in doing that, because most of the times we are looking through the side scope into what the trainee is doing directly under the microscope, but not exactly how the trainee is holding the instrument and going ahead with the steps. So here I'm trying to make a paracentesis with a lance plate. Another important feature that this simulator has is that it has a tactile feedback as compared to other older simulators where you could see what you're doing, but here with the help of this tactile feedback, you can also feel what you're doing. You get a small kind of vibration when you touch the eye with your instrument. So here you can see after doing the paracentesis, I'm putting in a viscoelastic through my cannula. And you can continuously do all these steps one after the other once you are an advanced trainee. But for the preliminary stage, you can also, all the steps that you're seeing on the screen can be done separately as single steps. So here I'm ready to enter the anterior chamber with my keratome, and you see there's that ring of light that comes as we see as we do the keratometry, as we see in the live eye, that dimple that we see, that we tell our trainees to look for while they are trying to enter the anterior chamber. And these are the metrics that I was talking to you about. It tells us the length of the scleral groove, how far behind the scleral groove was from the limbus. So all these things can be.
We're just running short of time.
All right.
We're just running short of time, Abhinav. So yeah, if you can just wrap up.
Yeah, so in the end, I would like to say that simulator-based training is definitely the way to go forward. And I'm sure soon enough, there'll be simulators present in the major teaching institutes. And there'll be a point where it could be, it could replace even the live surgical training and could be a prerequisite for going ahead with cataract surgery training and before going ahead on a live patient. Thank you so much.
Thank you, Abhinav. It's very exciting stuff that you showed us. Too bad that we were running short on time. With that, I'd like to thank all the speakers, especially Professor White, Dr. Reddy Garu for being the chairperson, Haripriya, Sheetal, Deepak, Rishi, Parikshit, and of course, Abhinav, you. Thanks to all of you for such wonderful talks. And I hope the speakers got some very important information from all of it. So back to you again to TOS committee.
Excellent and insightful talk by all our speakers and fantastically moderated by Dr. Murthy. Thanks to our chairpersons for chairing this session. Ladies and gentlemen, with this, we conclude the Sharat Babu